Why do health disparities continue to exist? I'm speaker Hyorin Nam from McLean, Virginia, United States. Over the last 2 decades, international attention to promoting health of developing countries have been rising dramatically. Despite the global developmental initiative progress, we can see still disparities in health as shown by the life expectancy map. In 1880, average life expectancy was about 29 years old. At this point, most of the average life expectancy of European countries, America, and Asia and Africa were about the same. In 1950, we can begin to see disparities between global south and global north. The average life expectancy at this point was 46 years old. Boom, in 2015, we see differences in life expectancy between global south and global north. In sub-Saharan Africa, India, and northwestern Russia, the average life expectancy is about mid-60 years old. Europe and North America, and South Korea and Japan is about 80 years old. I believe we want to tackle the root causes of health disparities. First, we can see the poor healthcare system. First, lack of knowledge. The recognition of illness and potential healthcare benefits are the prerequisite of healthcare demands. Where a large proportion of the population is in poor health, this becomes norm, and the recognition of illness are not easily recognized. 40% of the children in India are not immunized, and 30% of the parents had claimed they had not immunized their children because they weren't aware of vaccination benefits. Second, governance. We can divide governance into 3 sectors: mismanagement, absenteeism, and informal payments. Informal payments are payments to individual, the outside of the payment channel. First, mismanagement. Human mismanagement includes poor supervision and human resource management overall. In Honduras, 2.4% are ghost workers, which means they are in a payroll, but they don't work under organization. 5% have moved without management knowledge, which means improper relocation. Second, absenteeism. Absenteeism became much of the prevalent phenomenon in much of the developing world. In fact, 50% of the developing countries report absenteeism. Third, informal payments. Informal payment is also prevalent in developing countries as well. In Bolivia, for instance, 40% of the patients made illicit payments for care. Third, low resources. Low resources partly attributed to low healthcare expenditure. We see the substantial gap between actual health spending and health spending required to provide essential health services to accommodate increasing infectious disease and non-communicable diseases. For instance, while developing countries bear 90% of the world burdensome diseases, they only compose 23% of the health expenditure. We can also see the division in government healthcare spending per person as well. While lower income nations like Ethiopia spends $23 per person, lower middle income nations like India, Pakistan, and Vietnam spends $133 per person. United States spends $3,860 per person. UK spends $2,695 per person. Fourth, medical practitioners. Lack and uneducated medical practitioners. 50% of the healthcare workers incorrectly diagnosed and treated the malaria and diarrhea in Papua New Guinea and Pakistan. You will be greatly surprised to know the malaria and diarrheal infections are 4th leading cause of death in these countries. Second, brain drain of well-educated medical practitioners. When medical practitioners are well-educated in general pattern, they often migrate to wealthier countries where wages and environments are better. For instance, nursing vacancy in Canada, United States, and United Kingdom led to considerable increase in well-educated medical practitioners migrating from Philippines and some of the northern African countries, namely Egypt. Non-communicatable diseases in developing countries. With drastic reduction on infectious diseases brought by global health initiatives, though we see larger increase in concern in non-communicatable diseases. Non-communicatable diseases, unlike infectious diseases, are often influenced by psychological, lifestyle, and environmental factors, and they're non-transmittable, non-infectious. And 75% of the NCD, or non-communicatable diseases, that take place in developing countries. I divided non-communicatable diseases to 4 sectors. Let's go by one. First, urbanization. Urbanization contributes to physical inactivity and unhealthy diets and indoor air pollution caused by inefficient cooking stoves and poor air ventilation system. Second, globalization. With globalization, the multinational food and tobacco companies have penetrated and proliferated in every region of the world, and developing countries are no exception. As a consequence of these increase in surge of the multinational food and tobacco companies, we see increased consumption of tobacco, cigarette, alcohol, and processed food, which again contribute to heart disease and cancer. Third, regulation. Lack of basic consumer protection and public health regulations. I will give an instance in economic activity. When multinational food companies have been very aggressive in pursuing teens and women using billboard, music sponsorship, and other marketing methods that have long been banned in the developed world, Uganda and Togo and Namibia government have implemented restrictions against the marketing method. What happened? Then what happened was multinational food company has sued this implementation and delayed. As a result, consumption of cigarettes has increased and proliferated all over the developing countries, especially in East and Southeast Asia and Sub-Saharan Africa. Fourth, preventive care. With little access to preventive care, we see increased exposure to heart disease and cancer. So what can be done? I divided 2 possible interventions as a global health actor with 3 sectors. First, we have education. As we previously have shown in study in Northern India village, shown that the lack of awareness and potential recognition of healthcare benefits are the major culprit to exacerbating healthcare problems. Second, medical practitioners. We have seen in Papua New Guinea in Pakistan that 50% of the clinical health workers were misdiagnosed and treated the malaria and diarrhea, which again increased the death in these countries. Third, preventive care. We need to increase the civic awareness and knowledge in preventive care of non-communicatable diseases. Secondly, we see governance. Governance is mismanagement and absenteeism in informal payments. The government should institute some more of the restrictive healthcare system which to divert these kind of problems. Second, regulations. We have seen the lack of regulations in public health and economic activity contribute to an increased consumption of processed food and cigarettes. And third, urbanization and globalization. We can see to encourage the local food companies to increase access of fresh vegetables and fruits. Third, investment. We have seen the low medical capacity in many developing countries and lack of medical practitioners, especially educated medical practitioners. And preventive care are the major problem that exacerbate the health in many of the developing countries. Therefore, these education, governance, and investments are the core sector and core solutions to deal with these developing countries' perpetuating problems. So, let's move now. For more information, visit the globalhealtheconomist.com, which is my website where I upload and analyze COVID-19 related social, political, and health problems from multiple angles, including environment, inequality, statistics, monitoring, and healthcare issues. Thank you.